So good evening, everyone. My name is Kim Clark. I'm the Executive Director at Our House Addiction Recovery Center. I'd like to welcome everyone and thank you all for joining today's webinar on the stigma of substance abuse, changing the narrative, which is presented by Ashleigh Hyland from Community Addiction Peer Support Association, also known as CAPSA. So as well as the panel moderator, Rebecca Bernard, who's our program manager at Our House. So I would like to acknowledge that we are on Treaty 6 territory, a traditional meeting grounds, gathering place, and traveling route to the Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. We acknowledge all the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So before we get started, I would like to quickly introduce you to Our House for those of you that may not be familiar with us. So our vision is a community where fewer people suffer from addictions, and our mission is to provide an environment where individuals with addictions can embark on a recovery process directed towards a meaningful, productive lifestyle. We offer a one-year residential addiction recovery program for men 18 plus through shared accommodation in our 30-room facility. During this year, trained professionals guide residents through modules designed to equip them with the tools for long-term recovery. Dedicated to reducing the effects of substance use disorders and related mental health issues, we provide services unlike any other in Alberta and are one of the few year-long residential treatment programs in Canada. Additionally, we offer outreach services to the community at large, including individual and family counseling. For today's webinar, you can change your audio settings using the last button on the far left-hand side of your wonderful Zoom screen and enter your questions or chat with us using the chat button in the middle of your screen. So at the end of the webinar presentation, we'll have a formal Q&A where our moderator, Rebecca, will ask questions to the speaker on your behalf. Just a reminder that you are on mute by default, so if you have any questions or concerns, feel free to chat with us. Also, today's webinar recording will be uploaded to our website and social media following today. Now, it is my pleasure to introduce our speaker for today. So Ashleigh Hyland is a fully bilingual graduate from the University of Ottawa, holding an honors bachelor's degree in psychology. She shares a passion for education and awareness on substance use stigma, which has led her work with the Community Addictions Peer Support Association, where she plays an active role in the expansion of CAPSA's work with stigma and reduction and first-person language training. Ashleigh works as a stigma systems navigator to identify and correct instances of embedded stigma within organizational policies and practices that directly impact people who use substances. She also has a role as an all people, all pathways peer support facilitator, and most recently for computer assisted therapy to support people of living experience navigating the Breaking Free online program. So without further ado, I'm going to pass the presentation over to Ashleigh. Thank you.
Thank you so much for having me, and thank you everyone for being here. Just before we get started, I'd also like to say that I am a person of living experience with substance use disorder. So I've been living well for a few years now, and I'll get into a bit of my experience, both personally and from my educational standpoint. So without further ado, we'll get started. This is the Stigma Ends With Me session. What you'll get out of this session today is what we'll discuss is the spectrum of substance use and substance use health. We will explain how stigma impacts people's wellness, and we'll increase our understanding of non-stigmatizing language around substance use. So just as an activity, and I'll keep talking after this, but if you want to throw in the chat, have you or do you know somebody who's been impacted by stigma? So with CAPSA, our vision is to create equity for substance use health resources and funding to advance equitable care across the spectrum. So I'll get into what substance use health means, but from the equity standpoint, when we think about physical health and mental health, we don't presume an illness, and we have multiple supports for a lifelong wellness. So we'll get into what that all means. So what does substance use health mean, and why is it important to talk about? Well, just as I mentioned before, when we talk about our physical health, we don't always presume a physical health condition. You know, we're not always talking about a broken leg or perhaps a chronic medical condition. We're talking about how we maintain and increase our physical health. So that could be things like going for exercise runs, going for a jog, eating healthy, drinking water, getting plenty of sleep. Those are all things that we do on a regular basis to maintain or increase our physical health. And now we've been talking about mental health a lot more recently, and I think that that's wonderful. So when we talk about our mental health, we're not always presuming that somebody means that they have a mental health disorder. So when we're talking about mental health, we're talking about certain activities or certain things that we might be doing to maintain or increase our mental health. So that could be doing yoga or meditation. Perhaps it's journaling. Perhaps it's going to a support group to talk about things that have been going on this week that have been stressing us out. There's many things that we do to manage our mental health. And now we even have mental health days to address our mental health, which is wonderful. So when we talk about substance use, we often might assume that we're talking about a substance use disorder. But when we're going to look at the substance use spectrum, which is coming up next, we can see that there is a wide range of how people use substances and why people use substances. And it doesn't always mean that somebody has a substance use disorder. And in fact, most people do use substances throughout the course of their lives, and most without causing harm to their health or wellness. I also want to talk about how physical health, mental health, and substance use health all intersect with one another. So we kind of need to make sure that we have a balance between these three perspectives in our life to make sure that we have a healthy, balanced lifestyle and with our wellness. So for example, if we're having difficulties with our physical health, that could impact our mental health, which could also impact the way that we use substances, and vice versa. If we are struggling with our substance use, that could also impact our mental health and our physical health. So now we move on to the substance use spectrum. So as we can see, this goes from no use all the way to substance use disorder. So let's start with no use. Why would no use be part of the substance use spectrum? Well, you could have two kind of separate cases here. You could have somebody who's never used substances before, and that is their health with substance use, is that they're not using substances. Or you could have somebody who is abstinent from substance use. So they might be, living with a substance use disorder, and their substance use health is to no longer use substances. Then we have beneficial. So there is actually many beneficial reasons that people use substances. So for example, there's medical benefits. If somebody were to have a chronic pain condition, they would potentially be using opioids to address their physical health concern, and that would provide them benefits to address this. And there's also kind of our own personal benefits with substance use. A lot of us might have a glass of wine or maybe have a beer with dinner, or maybe we use cannabis to help us sleep better, manage some eating issues we might have, or help manage stress. So that would be a personal benefit of using a substance. It could even be as simple as, I'm having a really bad day, I'm going to have a glass of wine to kind of unwind. A lot of us do that. So a lot of us do find benefits with substance use. Then we move on to lower risk. So I would say honestly that every substance does potentially have risks. So even, we have low risk alcohol guidelines. We have these packaging warning labels on cannabis products. If you're getting prescribed medication through your healthcare provider, you come home with a whole list of potential side effects and ways that you need to manage that use of the substance to ensure, a low risk effect of those substances. So even, one glass of alcohol does have risks, but many things that we do in our lives have risks. But we learn to educate about these risks. We learn to manage these risks, and we incorporate how we manage those risks in our day-to-day lives. And that could go with just about anything that we do. So for example, it could be having a ride home after consuming alcohol. It could be managing how much alcohol you're using, or how often you're using it, or when you're using alcohol. These are all things that we do around our substance use health to manage lower risks. Then we move on to problems occurring. So you can definitely experience harms related to substance use without having a substance use disorder. So when we're talking about substance use health, it's really important that we can talk about our substance use and how substance use might impact our health. When we're experiencing those harms, whether it be to our current lifestyle, whether it be with our family relationships, our friends, our work life, there might be many ways in which we could experience these problems. And it's really important to be able to talk about it. oftentimes a lot of people don't have a choice but to wait until they're sick enough to receive help because there is not enough services to help people along this spectrum of substance use. And then we move on to substance use disorder, which is a diagnosable medical condition, which can be diagnosed under the DSM-5. So I want to note, what does substance use help really have to do with all of this? This is not a one-stop train. So you wouldn't just go from here all the way over to the end of substance use disorder. It's not a one-stop travel point, right? So actually, when we're talking about substance use health and when we can increase, supports and services around just talking about our relationship with substances and how it might impact us both positively and negatively, we're able to have our support systems, our people in our healthcare systems, help us move along the spectrum to where we want to be. So they're standing beside us and leading us, we're leading them into where our substance use health goals might be. So for example, if you're talking about with your support person, it could be a family or a friend, or it could be somebody in the healthcare system, or maybe somebody in peer support, and you're talking about how you're using substances. You wouldn't personally say you have a substance use disorder, but you're experiencing these issues with substance use, or you might notice yourself using more substances than you might have been using before. You can direct that conversation to where your goals might be. So maybe you want to move over to this side of the spectrum where you're at a lower risk of experiencing these harms, and that you're experiencing more benefits than you would harms, or perhaps that goal might be to no longer use substances because that would be the best choice for your substance use health. Each person has their own kind of journey with that. So I want to make it clear that it wouldn't be if you're using substances, you're just slowly kind of moving along the spectrum and you stay at substance use disorder. Many people do find wellness when they are living with substance use disorder, and we're able to kind of move around the spectrum to where we hope to be. And we have to increase those supports to help us get there. So what differs a substance use disorder from the rest of this spectrum? So when you're repeatedly exposing your brain to substance use, and let's say you have potentially contributing factors that could contribute to substance use disorder. So for example, you might have genetics that run in the family for substance use disorder. Perhaps you have mental health disorders that could be co-occurring with your substance use disorder, which is called concurrent disorders. Perhaps you've had adverse childhood experiences, or you've experienced a trauma. So in those kind of contributing factors, when we're repeatedly exposing our brain to substance use, we're actually changing the neurochemistry in our brain that is related to craving, reward seeking, and decision making. So it affects our executive function. So with that, it increases the reward pathway in our brain, and it decreases the fear pathway, which in itself makes us feel good, which prompts that response in our brain to continue to use that substance that is making us feel good and decreasing those potential negative things that we're trying to cope with. So for example, when you're coping with physical and or emotional pains and traumas, perhaps you're managing grief, or exactly as I said, you've had some traumatic experience, which could encompass many different things that could happen in life. Perhaps it's a job loss, perhaps family conflict. There's so many things that could happen throughout the course of our lives that could impact our physical health, our mental health, and our substance use health. So our brain's reward-seeking activity then becomes hardwired for survival, which is when with substance use disorder, the substance becomes a point of survival. Alcohol withdrawals and opioid withdrawals can lead an individual to feel as though they will die if they don't take another substance, which is why it becomes fairly difficult to kind of get through those withdrawal symptoms. And with alcohol, you very well are at risk for death with withdrawals, depending on how serious they might be. So this is very difficult to be able to manage, especially if you're doing it alone. Stigma can prevent people from accessing supports and services when they're faced with substance use disorder. So a substance use disorder is a diagnosable medical condition. And this is what differs the substance use disorder from what we saw on the rest of the spectrum. It's when a person compulsively craves, seeks, and uses the substance, they're no longer able to make those healthy choices, and they continue to use despite negative consequences. So I really want to touch on this last point because I think it's really important. Continues to use despite the negative consequences to themselves and others. Oftentimes we might question, why doesn't this person stop? If they really cared about their friends or family, then they would stop. Can't you see all the harm that it's causing? But as I mentioned, our brain's chemistry has actually changed in a way where the substance becomes a point of survival. So this is what makes it difficult to see substance use when we're faced with substance use disorder, especially if we're handling that by ourselves. So with that, I mentioned that there's many pathways to achieve wellness. And what the important part is that the substance use itself doesn't necessarily need to change. For some people, as I mentioned, abstinence would be their health goal. For some people, it might be reduced use or harm reduction, switching to a less harmful substance, trying to get to the lower risk end of the spectrum. So it might not be the substance use itself, but it is the relationship with the substance that needs to change in order for our brain, due to neuroplasticity, to be able to rewire in a sense where that substance is no longer that survival response and coping mechanism that some people may be using to address these concerns that they might be having. So stigma is best understood as a deeply held set of false beliefs about a group of people with at least one attribute in common. So this allows for the judgment, oppression, and discrimination of those people to take place. It's done either by overt actions or by silent complicity to those actions. So overt actions would be kind of like that direct stigmatization, like when you see somebody and you might judge them or shame them or even label them with stigmatizing terms that people use against people who use substances. Or it could be seen in a healthcare setting, refusal for pain medication for a patient who might be suffering with pain because it might be seen as drug seeking. So this is kind of an overt stigmatization of somebody who is using substances and is seeking care. I also want to note on the silent compliance. So oftentimes, if we feel as though we're not doing something directly, that we're not part of that issue and that we're not contributing to that issue. But we've seen this a lot more recently, especially with the recent Black Lives Matter movement, when, if we're not we're not directly doing it, then we're not part of it, and it has nothing to do with us. But what we saw from that is that we're all part of that conversation, and we all need to take action to reduce discrimination and stigma. So with this kind of scenario, for example, it could be almost described as the bystander effect. So if you ever see those videos on Facebook or YouTube where somebody's injured and there's kind of a crowd around that person, but nobody seems to be reaching out to help the person. So the bystander effect is when each individual is under the assumption that somebody else will reach out and help. But that effect then causes everyone to not reach out because of that assumption that somebody else is going to step in and do it. But then when we see that one person who does reach out, you kind of notice everyone kind of flocking towards, and everyone starts helping out as well. So that's the same with stigma, and when we're not directly acting towards that reduction of stigma. So if we don't take action and we don't take a stand, whether it just be talking to somebody about how they might be stigmatizing a person or someone you know, or even yourself, or even in a healthcare setting, advocating for mistreatment that might happen due to stigma. So it's really important that we ensure that we are all doing our part to reduce stigma, because stigma is one of the biggest barriers to access to treatment, to services and supports to address substance use disorders. So there is different types of stigma. We have self-stigma or internalized stigma, which is the internalized negative beliefs resulting in feelings of shame and worthlessness. Self-stigma is derived from social stigma. So we wouldn't really have self-stigma if we didn't have social stigma. So social stigma is how people stigmatize others, how people might stigmatize somebody who uses substances, or even how people can stigmatize somebody who doesn't use substances. You would never get questioned why you're not having a glass of alcohol at a gathering, but you definitely would be questioned, for other substances, right? So alcohol is one of those substances that has become so normalized that you would actually be stigmatized if you're not using it, which can be really difficult, especially for somebody who is living well with substance use disorder and is not using substances as their substance use health. It might be difficult to continue on that pathway when you're met with that stigma for not using substances. Then we have structural stigma. So this is at the policies and practices level. So this is when social stigma kind of pours into the policies and practices. So we have people who might have biases and stigmatized perceptions of those who use substances get into those positions of decision making and policy making and decisions of where the funding goes. And that's how we can see how systems can be broken in a sense where the systems aren't serving the people that are in need. So the impact of self-stigma, it leads to feelings of self-deprecation, low self-esteem, shame, worthlessness, decreased self-efficacy, and a self-doubt about one's ability to function adequately as a member of society. Then we move on to the intersectionality of stigma. So I talked about the different types of stigma. I like to call this the different layers of stigma because the intersectionality describes the way that we can actually have additional layers of stigma added on that aren't just substance use related. So for example, let's say you had a person who was of low income, perhaps of low education, perhaps not employed, or in a low social class. And then you would have somebody who is the opposite, essentially. They would have high social class, high income, they may be in a position of power and they're using substances. The person on the other end is going to be perceived a lot differently in society and actually stigmatized more in society because of those intersectionalities of different factors that might exist. So for example, even with culture, we have specific substance use stigmas attached to cultures. So for example, Indigenous people have stereotypes attached to them for alcohol and substance use. So for example, if you had an Indigenous person who was seeking medical care for a reason that is unrelated to substance use, they might be met with many more additional questions about why they're there, are they pain seeking for medication, and etc. And all because of these really deeply held embedded stigmas that exist for certain cultures around substance use as well. So we can see how if you add certain layers on top of each other, it then further contributes to somebody's experience of stigma. The impact of stigma also leads to prejudice and discrimination. So it can influence policies, systems, and funding, as I mentioned. People then become isolated and excluded from society. And this can even occur inside the home, surrounded by family members and friends. So how does stigma affect somebody's wellness journey? Well, there's actually an evidence-based study that has been done to show that there are actual effects of stigma that can harm somebody's health. So it's associated with poorer health outcomes. It also creates barriers to effective care and accessing services, and it puts people at risk for chronic stress and poor coping responses. So we even stigmatize people who are in the recovery or the wellness community. So not only do you become stigmatized for a substance use disorder, you can even be stigmatized for being in recovery from a substance use disorder. And that can be really harmful for people to talk about it openly because, when we say that we're in recovery, we're then confirming that we were once sick, and that can elicit negative responses from people. So some common misconceptions that we see here is once an addict, always an addict. They can't take too much stress or the reoccurrence will occur. Wellness isn't for those that need it, it's for those that want it. Job loss and redlining in recovery. So redlining is, let's say if you had to take time off due to substance use or substance use disorder and you came back to work, you would kind of have that glass ceiling effect where you wouldn't really have opportunities to expand within the organization because they're kind of just keeping you still in that one position that you're in. But on the opposite end, wellness is possible. So recovery is possible. There's many ways that people do achieve wellness, and it is possible with the right services and support. So there's even stigma with medication. So people who are using substances to actually address their substance use disorders. So this could be methadone, it could be Suboxone. There's medications that are used to address opioid use disorders, such as opioid agonist therapies, and even medications to address alcohol use disorder. But sometimes the perceptions of care providers might stigmatize these medications and only kind of offer you their opinion of the service that you should have, which could actually be a barrier and close many doors for you to be able to achieve wellness. So when I'm talking about wellness, I want to note that the important part, what are we wanting to achieve with wellness? What is that goal? The goal is increased health. We want to ensure that we're supporting somebody's health. No matter the way that they want to get there, we want to ensure that we are supporting one's health. There even is stigma with concurrent disorders. So sometimes people will try to access concurrent care, and they're being met with, telling you that you need to address your substance use disorder before we can help you with your mental health, or vice versa. You need to fix your mental health before we can fix your substance use disorder. When in fact, a coordinated and integrated approach has reflected the best practices. And there's actually not enough services for concurrent disorders, but many people who do have substance use disorders actually have other mental health conditions as well. So, and as I mentioned before, our mental health impacts our substance use health. So when we're addressing substance use disorder, we have to look at how our mental health might be impacting our day-to-day activities, and how it might be impacting our life, how it might be impacting us in our families, in our homes, etc. So stigma can be reduced through awareness, education, openness of conversation, having compassion, and stigma-free language training. So there are words that hurt people, and there are words that can heal. There is non-stigmatizing language that respects people's worth and dignity. It focuses on medical terminology, and it promotes people's wellness journey, and it avoids perpetuating those negative stereotypes and biases. So I'm going to show you a study that has shown that not only does non-stigmatizing language positively impact people, it also shows how using stigmatizing languages also negatively impacts people. So here we have a study which was done by John Kelly. He's a Harvard professor. And what he did was he separated two groups of people. He asked them the same set of questions, but the only difference was he used stigmatizing language in one group and non-stigmatizing language in the other group. So for example, he said, does a substance abuser deserve treatment? Do they deserve punishment? Are they a social threat? Are they to blame? Are they to blame for their substance abuse? But then on the other side, he asked, does a person with a substance use disorder deserve treatment? Do they deserve punishment? Are they a social threat? Are they to blame for their substance use disorder, and so on and so forth? So as you can see here, that when we refer to somebody as a substance abuser, less people were likely to think that that person deserved treatment. More people were likely to think that that person deserved punishment. More people were likely to think that the person was a social threat, and increasingly more people thought that they were to blame for substance abuse. But on the substance use disorder end, you can see that there's actually an increase for people who believe that, yes, if you have a medical diagnosable condition, a substance use disorder, of course you deserve treatment for a medical condition. Less people were likely to think that they deserved punishment. Less people were likely to think they were a social threat, and significantly less people thought that they were to blame for a medical condition. But what's also important to note here is that 23% of people still believe that a person with a substance use disorder deserves to be punished for a medical diagnosable condition. And this study was done with public health nurses, so those who are providing the services. So that just goes to show how deeply embedded stigmatization of people who use substances and of people who have a substance use disorders are. throughout our systems and services. So when we're talking about person first language, we are talking about the person first because they are a person before they are a medical condition. So, for example, instead of saying substance abuse, which kind of perpetuates that it is the person's fault for having a substance use disorder, we would say substance use or drug use, instead of calling somebody an addict, a junkie, or an alcoholic. We would say a person with a substance use disorder. Instead of saying former drug addict, we would say a person who's living well, or a person living well with substance use disorder. And another example would be instead of referring to somebody as clean, because when we refer to somebody as clean, we kind of perpetuate that they were dirty before when they were using substances. So instead, again, we would just say a person living well, or a person living well with substance use disorder. You could even say a person with living experience, as I said for myself. There is many ways that it can be put, but the important part is to use the person first. So they are a person before anything else. And when we're using stigmatized language, we're essentially putting that person in a box solely based on their substance use. So another study with John Kelly again, so he had asked two sets of groups if they supported the legalization of this service. He gave them the same definition. In one group, he asked if they supported a safe consumption site. And in the other group, he asked if they supported an overdose prevention site. So here we can see that there's a significant increase in support, and just simply with a name change. And why is that? A safe consumption site obviously isn't a stigmatized term, but it's the way that stigma and society kind of attaches itself. So society has stigmatized safe consumption sites, so we have those stereotypes of who we think those people are that go in and use those services. But when we call something an overdose prevention site, it elicits those positive responses of, yeah, of course, we would support overdose prevention. So it can be seen that, even the language that we might use, especially with policymakers, decision makers, or even just in our healthcare settings and socially in our conversations, that, simply changing the way that we talk about things can actually elicit positive responses. It can elicit compassion and elicit support for those people. So another activity, if you just want to pop in the chat, if you or we are going to address stigma, what qualities should we focus on? So just plop that in the chat while I keep babbling on. So this is an invitation to be an ally. So supporting somebody and supporting the people who use substances and have a substance use disorder. And this involves developing a more accurate appreciation of the realities and possibilities of increased wellness to overcome those negative stereotypes, promoting increased health, recognizing the harms done by stigmatization. This helps remove barriers to access to treatment and supports, and it promotes positive interactions and language. So being an ally can involve sharing your experience as an ally, telling people why it's important, what interested you in supporting others, maybe kind of that personal experience that you might have that led you to want to support others who use substances. Connecting with new friendships and maintaining your core support network. Also, letting them use their energy for their own struggles. So ensuring that when you're supporting somebody who has a substance use disorder or is using substances and facing stigma, that, we don't stand in front of those people when we're supporting them, we stand beside them because they know what's best for them personally. They understand the true impacts of stigma on their own health and wellness. So it's really important that we let them lead the conversation of where that energy needs to be directed and where we need to tackle first. It's also important to have your own roots. So what really brought you forward to become an ally, something that really interested you, and it could be a personal experience, it could be your educational background, but it's really important to have that as well. And most importantly, be yourself, ask ask questions and learn. This information is constantly evolving and changing. So it's really important that we are kind of sticking with that and that we're increasing our knowledge on these topics. And understanding the different ways that we change our language and the different ways that stigma might be harmful, so that we can best support individuals of living experience. So with that being said, this is a QR code. So if you take out your smartphones and open up your camera, you can actually scan this code and it will bring you to a hub of evidence-based information and resources on stigma and person-first language. And I can also provide this to our house so that if there's participants who are interested in having it and don't have the time to scan it right now, we can definitely make that a shared material. So that kind of brings us to the end of the session. And I guess I will open up the floor if anyone has any questions or any comments or maybe something that they'd like some more clarity on. And I will stop the screen so that I can see everybody. Yes, Mike.
Mike, addict, alcoholic. When you were mentioning about medication, and I have to kind of disagree on that, because people who are in addiction and people were told by doctors to take their medication in order for them to stabilize. And focusing on when I was living in Ottawa when Narcotics Anonymous first started, and I was one of them that helped out 1984. There's a lot of people in NA were telling people to quit their medication in order for them to stay clean. Well, some of them did stop, but then some of them committed suicide. And they needed that medication to focus. Same as me, I'm taking medication right now for almost 21 years. And I will not stop because I see myself, before I took the medication, I was almost ready to really hurt people. And that's why I'm staying on the medication. So I'm not totally disagreeing against you for what you said, but I am focusing on, there's a lot of people who need the medication.
Well, perhaps I wasn't clear. I in my conversation, we do support medication. In the slides, it was to show the stigmatization that people do stigmatize others for using medication, but for us, we support the use of medication for any health concerns. It's just to show that there is stigmatization that is tied to it, and we want to reduce that stigma so that people who are using medications can do so without experiencing that stigma. So I apologize if that came off the wrong way. It was more to just reflect on the societal stigmatization of medication, but absolutely that is 100% supported. Thank you for your question. And also, I noticed in the chat, I also want to mention in NA or AA groups, or even just people of living experience, if someone refers to themselves as an addict, we encourage people to not correct those people using those terms, because if somebody is using that to identify themselves, then that is the way that they want to identify, and that's totally fine. If anything, we could model person first language, and that there are other ways to talk about substance use and people who use substances, but we strongly encourage to not correct people if they're referring to themselves as an alcoholic, as an addict. It's more specified to people who may not be having or may not be using substances or have a substance use disorder and might be using those stigmatizing labels against others, because not only does it affect the people that you're talking about, we saw in the studies that it actually affects kind of the perceptions of other people, which could impact policy making, decision making around funding, et cetera. So it's more for that societal kind of perpetuation of the stereotypes that exist. But 100% if somebody is saying, hi, my name is blank and I'm an alcoholic, we wouldn't correct them for that. And that is their way to refer to themselves if that's what they choose to.
Sorry, can I just jump in? I don't know how to put my hand up in this thing.
Totally.
I put it in the chat, but since you were focusing on that, I work for a recovery house in a small Alberta community, and we've encouraged, not, but just encouraged people during our group sessions to identify as an addict or alcoholic in recovery, or a recovering addict or alcoholic. And then it's their choice if they want to use it. And we found a real shift in the people and how they were interacting and discussing when they started to refer to themselves as in recovery, instead of just, I'm the addict, I'm the alcoholic. So again, we don't force it, but we really do encourage it. And they hear the other people saying it, newer people coming in, and it really changes the dynamics of the conversation, we find.
Oh, thank you for sharing. Absolutely. Especially in a recovery journey, we want to talk about, those successes that we've had and celebrate that we have been able to overcome substance use disorder. So I can absolutely see that that would be beneficial in those circumstances, 100%. Mike.
Sorry to interject again. As that lady was saying, or Tammy was saying about, she was working in a recovery home. Well, I was coordinating a recovery home with 25 guys in that recovery home, and there was 10 guys in the Hill, meaning there's dual addiction. They had AIDS, they had alcohol, they had drugs. Now, the socializing back then, when the University of Ottawa came down and brought these volumes on the research on the AIDS, people were very adamant to even touch the people with AIDS. But when, I think it was when they came down, and I encourage everybody in that recovery home to just not push anybody, just and not say, well, let's all get along. It's everybody's decision on what to do. Now, since my contract was there's only one person went out drinking, because I told my psychologist and the secretary to just understand where they're coming from, because that's what it's all about. When the people were in recovery home, we call it recovery then, but now they're calling it treatment. But anyway, back then, what I look at as a person, if I am very nice to people, it makes their recovery simpler, easier, and focusing on their recovery. And also, I was a peer support worker in Kenora for Sunset Country Psychiatric Survivors. I was appointed for these positions, not because I got all this university level or anything. I was asked because I acted and talked and cared and loved people. And that's why I was asked. So I think we talked before, Ashleigh. You're based in Ottawa.
Yeah.
Yeah. It was I was way back when I was going to the Carling to the Ottawa Mental Health Hospital there for one of our meetings there, where Gord was taking care of it. So yeah, we talked a few times.
I think I recall we might have been emailing back and forth the other day, right? Yeah. You brought up a really good point, and something that Gord mentioned to me as well. When he was in the hospital for his substance use disorder, he mentioned that impact of being in the hospital for several days and not one person coming in to check on him. Nobody touched him. And that really had a toll on his health. And when he shares his story, it was the support and compassion of people that actually drove his recovery and wellness. And for myself as well, I was living well for 6 years with substance use disorder, and I experienced a recurrence last year. Now, I was too scared to go into treatment or anything like that. But what really, really helped me was the support of the people who I worked with and the support and compassion of the people around me who helped me kind of address the trauma that I went through, which then helped me with my substance use. So I totally agree with you on your comment of the importance of compassion, really taking a genuine support for somebody who may be struggling with substance use and trying to seek their wellness. Any other questions? If you want to just jump in and ask something, feel free.
I have a question here from the main room. They're just asking, hi Mike, how you doing? I'm just asking, how do you get diagnosed?
Well, it depends, because a lot of people don't get diagnosed. So it really depends on where you're going. And it would either be with a psychiatrist or your general health practitioner. There is a set of 11 criteria that you would meet. There's different intensities as well, low, moderate, and severe. But I think a lot of the times it's difficult for people to kind of get that diagnosis. And a lot of the times that diagnosis is what you need to have in order to get the supports and services. So that is another thing that prevents people from getting access to help, as well as if they're not sick enough, then they're not going to be able to get the help that they need. But oftentimes we see that that's not a good way to address concerns that people might have with substance use. So if anything, the diagnosis itself should not deem if somebody should be able to receive supports and be able to talk to somebody about their relationship with substances and how it might be impacting them. Thank you for your question.
Okay.
Nicole.
Yeah, hi.
Hi.
I guess the question would be, say I'm in recovery and have been or am from alcohol abuse, so for 22 years, and we've been working in service, and I find it very challenging because I do suffer from depression, and I guess I realize I never did before, but that I would have panic attacks in the past and not realize what it was, panic attacks and anxiety. And sometimes I have difficulty sleeping as a result, but I really feel it's important to give back on that level and to help, as it makes me feel good afterwards, even though it has its challenges. But I find not everyone is I suppose practicing spiritual program, and sometimes there's some strong ego and personality, and comes in forms of sarcasm. And I know from a recovery point, it's coming from fear and other places, but still, I like that you use the example of if somebody steps up, but nobody does, and it's just a constant comments, and I found it quite painful and hurtful, and try to have my relationship with God and know that I have I have that support, my higher power. And, I know some people don't like that word. That my higher power is can find in nature, and I dropped some things in the chat about finding balance as I did presentation
Yes.
at a college with a CPC cooperation with the professional community. And one of the students there had a bracelet on from the hospital and got up after the presentation. And he said, it doesn't work. It's only for 5%. And is obviously, he showed up at the class late and then he got up and I was just not horrified. I saw he was suffering and he was in pain and he says it doesn't work. And the teacher that was there, she was saying, well, it doesn't always work, like AA or whatever. I mean, whatever fellowship it is, 12-step fellowship or whatever course of treatment. It's not, I understand what he was saying. It's not always necessarily, as you say, there are alternatives of getting people to a certain level where it's manageable and offering support. And it's so important because me, like I'm saying, it's been very challenging for me. And the way people speak at some area meetings to each other, I mean, it's horrible. And I don't understand why nobody's defending the behavior, why we have to get into arguments, like say in a steering committee about behavior that's unacceptable. I mean, we're talking, there could be newcomers in the room, people that are just starting, that want to learn about the structure. And then we wonder why people aren't stepping up for service because it's too hard. We already have challenges. But I have a hard enough challenge just getting through my day and finding balance. And so I don't know if there's any advice you can give other than trying everything. I have spiritual advisor, I do my readings, I try to have a balanced lifestyle, but I'm just can't understand why, it's also a French community. The French community don't always necessarily study the big book. That's more the English community. So it makes a big difference in your recovery if you include that in your recovery, as well as meetings and discussions. And, because we don't start talking, that's the magic. When I first came in, I identified immediately because people are talking about the feelings and the emotions. That's something I never experienced as a child. I just experienced my mother saying, stop. But I didn't know in my head, I didn't know that I wasn't well.
Yeah.
That I wasn't getting support, emotional support. And I noticed we had some friends and the parents are always praising them, how great their marks were, or everything. I was like, really? I mean, it's just, like she just blew dry your hair, and it was always constant praising for them. And I couldn't understand it. And I didn't feel like and it was kind of dysfunctional. It was like, if I didn't come home with the gold medal, if I accomplished something, then it was always not, I felt not good enough, never enough. So I don't know. So maybe I set that pattern and people can read on it. People can read up on it. And we talk about it, and we supported that in meetings and when we're in discussions and shares, but then the social mask comes on when we leave the meeting and then we go out into society. So I don't know what you can say about that, if there's any.
Yeah, so two things that that you brought up that kind of rung some bells for me. So for one, we talk about staying well when we're helping others. So you talked about how you're in a position where you like supporting other people because it makes you feel good as well. You want to give back. And then there's also that aspect of kind of continuing to manage your own mental health concerns as well. And that's something that I can completely understand. When I'm providing computer assisted therapy or peer support, I get those same feelings that this is great and I'm giving back. And also I have to take time for me and have some balance because some things might elicit negative responses in myself. It might bring up some things of my past that might be difficult. And how am I going to manage my health around that and my wellness when I'm in the position of helping people? But I also need to remember that, living well with substance use disorder, you actually have to constantly continue to work at that. You have to continue to work at your mental health, and you have to continue to do things to cope with physical and mental pain so that you are in a good position with your health. So we call it staying well while helping others. And I found a lot of support in groups. So when I'm supporting other people, but also taking time for myself to seek other groups so that I can talk about my week and what's been going on with me and how, how heavy my workload might be or how that might be affecting me, so that I'm also supporting myself as well. And then another thing you mentioned, when no one's standing up for people or nobody's stepping in. So another thing that might be helpful is, we talk about calling people out, but then there's also calling people in. Calling people into a conversation where we can say, hey, I just wanted to talk to you about how this might be harmful to the others in the group, or how some of the words that you might be saying could be negative and can be perceived, in a negative way for others. So could we talk about how we could address this and how we can best support the group together? So we talk about it in a way where it's calling people into a conversation, because sometimes when we call people out, we can be met with kind of a defensive response, or people might not hear us well because we have good intentions. Everyone, has good intentions and a good heart in these fields, but sometimes it's about calling people in to have a conversation, and kind of like that partnered approach where you can really talk about it in a good supportive way. So I hope that might have helped in some of the things that you brought up.
Yeah, I'm realizing some of my not behavior, but I'm thinking people interpret and then they may get defensive. So I'm thinking that maybe I'm contributing, although maybe I think it has been, or unconsciously, because I keep on experiencing that over and over again. And so it's, anyway, I guess I just thought I'm trying to contribute, and I just thought I would just bring it up and just admit that it's something that I'm struggling with. And sometimes sharing what you're struggling with and people identify can maybe help other people like come forward, or just say, oh, I can relate to that. It makes me think of that. So I don't know. It's like sharing. You feel responsible when you're in a meeting that you share also, because I guess I had the self-esteem issues in the past. Oh, well, I still do, obviously. I mean, we never get 100%. It's always like a yo-yo, up and down and up and down. But I realize if people's shares help me, then maybe mine can help people. So that's why I try to contribute.
Well, thank you so much for sharing. I really appreciate it. So we do have a couple minutes left. I'll take those two hands up, and then I'll pass it over to Rebecca for the next portion. So Mike, if you want to go, and then Corey after, and then we'll move on to the panel.
I want to hear the gentleman before right now, because he's got something to say, and I just feel he's got something good to say.
Sure, absolutely.
All right, for the opiate clients that have come in, a lot of them deal with the stigma in and around methadone and Suboxone use. And even with the family members and friends that they're working with or trying to build a relationship with, how do they get around that stigma? What kind of advice can you give them that they can kind of break the ice with them, right?
Yeah, that's a really good question. So I always bring it back to health, because sometimes we have our like ingrained biases that exist of what we think somebody's recovery should be and how we think they should get better. So that could be, family members and friends who have these opinions on, well, this is what I know, and this is why, this is the only way that I know that you should get better. So this is what you need to do. So some advice for kind of breaking the ice around that is when we talk about health. So not even talking about the recovery, but there could be immediate concerns with somebody's health. Like right now, you are experiencing pain, and there's some medication that you need in this very moment to address your health. And then looking at it from the long-term perspective of, we want to address your health, and we want to do this in a way where we can get you to where you are at. So often we always say that it needs to be a person-led approach where the individual, is able to share what they would like, and how they would like to achieve their wellness, however they might see fit, and then having, the support of their friends and family. But often I've seen it where, if we talk about the real health concerns that we might have and make it about the actual health of the person and how we can best support that, it might help to kind of explain that these medications such as methadone and Suboxone are going to address their health and put them into a better place to continue on their pathway to wellness. So that would be addressing their immediate health by using methadone and Suboxone, and that's something that you can use to get them to where they need to be. It could be a stepping stone to the next goal, or it could be something that helps manage the harms that they're experiencing currently. I hope that helped.
Thank you.
You're welcome. And Mike, if we want to close up with you, and then we'll hand it off to Rebecca.
Yeah. See, when I was in panic attacks back in actually 2001, the ACT team was working with me. And whenever you get about panic attack back then, if anybody has today, you always think when you're in a panic, you count backwards, and every second you count says this is not really happening. And it really works. Also, secondly, and thank you, Nicole, because, oh my God, like you were telling my story. You see, when I went to Kempville conference for facilitator and facilitating meetings, because I was facilitator for manic depressive meetings. And also I'm registered in mood disorders in Toronto, but I'll go anywhere. Anyway, let's not get into that logistics of it. But in order to, when a person's really angry and a person, if you're noticing he's really getting violent, then we ask them, how's your family doing? How's your kids doing? And that breaks the ice with him. And also it understands where he's coming from, that when I say those things, he feels that we care for him or her, because this is what it's all about. And thank you, Ashleigh, because you brought up that subject about, talking to the person and inviting them in. This is what it's all about, inviting people in if they feel left out. Thank you.
Thank you so much. And thank you for sharing, Mike.
Hello, everybody. Thank you so much for being here tonight. And thank you, Ashleigh. That was a wonderful presentation. And hopefully, everybody learned a lot about the stigma and how it really has quite a bit of impact. I was surprised, actually, in terms of just the language, the study. Like, wow. We see it every day, but I didn't realize, tangible, how much of an impact that is. So for the rest of the evening, we have 4 gentlemen here with us who have interacted with our house in some capacity over the last few years. And so we've got a few questions that we're going to ask them, and then we'll open it up to some questions at the end from everybody in the audience. So what I'm going to do is basically, I'm just going to ask the question and then have the men answer and kind of discuss as we go along. So you're off mute now, gentlemen?
Yeah.
Okay, so I'm just going to quickly introduce. So I'm going to go from my left to right. So maybe you just want to wave when I introduce you. So we've got Sean, first on there, yeah. Thank you. And then beside him is Sean as well. And then beside him, we have Ed. And then we have James. So thank you so much. I'm going to start out with the question about our house, in fact. So what qualities did the staff here at our house have that you felt helped you in your journey?
Any order? Hi, it's Ed. Yeah, I would say there was a great deal of empathy. There was a great deal of patience and understanding and compassion, and something akin to love. It was I felt the relationship between myself and the counselors to be, very beneficial for both sides.
Thank you, Ed. Anybody else?
I just have Sean here. I just have to say, like, the individual counseling is fantastic, but in not just saying that, it's because I have my own individual counselor, the interactions that I got with every counselor and every staff member that is here is bar none. Like, I've got to know, it's not just that the counselors got to know myself on a personal basis, but I got to know you guys as well on a personal basis. And it's that give and take that makes that trust and that bond. And so, like, yeah, like I said, like Ed said, there's tons of empathy and tons of understanding and tons of love here.
Yeah, I would add to what the guys are saying, just that, hello, I'm Sean, we already introduced, but hey, it's me again. So there's things, I agree with the comment about the individual counseling. But one thing that struck me recently is I'm in a position where I'm trying to plan for things outside of the house, and I had a bit of a hiccup in my planning for school. And what struck me was sometimes their ability to attack things as a whole team, because my counselor knew the situation that was going on, which was I was denied getting into a program in school, and by the very next morning, and I have a tendency to catastrophize things as an addict. By the very next morning, the whole counseling staff knew, and they were all reassuring me that things were going to be okay. And with a house of 60 guys, they still somehow take the time to understand where each individual is at as a team, and I have an appreciation for that, for sure. Yeah.
It's not just a house of 60 guys. Like, I graduated 5.5 years ago and I still come here for counseling. I see my counselor every 10 days to 2 weeks. And I know that there's other alumni that continue to come here. So, they have the pressures of the 60 men that are here on a daily basis. But there's the rest of us hangers on that still need some help, and the help is offered to us on a regular basis.
I can also add for that, like, relapse has been a part of my story. The staff have been excellent in getting me back. For them, it doesn't seem to be a 9-to-5 job. I know some of my calls have come far outside of office hours. There have been situations that have come up on weekends and in evenings, and someone on staff is always available to help me outside of their regular work hours, which I think that needs to be brought up, because I mean, they don't just go home at the end of the day. I still have issues that arise no matter what time of day, right? And they've always been there.
I got another thing too, like, they've always been up for putting us for outside help as well. Like, I've dealt with sexual abuse in my past and as a child, and they hooked me up with SACE, the Sexual Abuse Center in Edmonton, and there's the outside resources, not just within the house. So they steer me in the right direction in that sense as well. So it's not just all in-house. They steer us into the right directions outside of here for outside help as well. So that's a huge bonus in my opinion.
Wow. Well, thank you. It's very informative for me as well. I appreciate that. What kind of barriers did you experience when you were trying to address your substance use? Like, did you find that there were barriers that you were met within the healthcare system, within your family systems, within your social networks? And then how did that impact you?
Talk to me.
No, to the four gentlemen there, Sean and John. Yeah.
How come we still have the microphone?
I'm James. I'm an addict. I think the impact that it had on me, like trying to get back into treatment, because I just recently relapsed of 2 years of sobriety. I had a little bit of an issue trying to get back into treatment because lately, since the government's covering the treatment facilities in Alberta, there is wait lists for up to a year. So guys like myself who are in imminent need of that, it makes it very difficult because a lot of people who are struggling with addiction to begin with, they don't have that time to wait a year. You know what I mean? Like a lot of guys can't even make it a week without passing away, you know? So being back and forth from the hospital, back on the streets, and then going to work, and then, you know, completely destroying my life a little bit more, and then back into the hospital, and then, you know, doctors and social workers trying to get you into places and stuff, and then by the time you get there, the bed's already full or something like that, or, you know, they'll just like, oh, well, you know, you're a little too far gone, you need to go to detox, and then detox denies you because you're too aggressive. You know, it's just like, what are you supposed to do? So the fact is, like, I actually spent maybe a week on the wait list to get into here, and they actually got me out of the hospital in here. And since being here, it's, you know, I've not only experienced like the willingness of the staff to actually help me out and guide me back into like a healthy lifestyle and stuff like that. But the thing is, like, they were willing right off the bat just to take me. They didn't want to make me wait, you know, they didn't want to give me all these excuses of, you know, why you can't come and blah, blah, blah. It was just, you know what, how long is it going to take you to get here? And that was just a fact, and I just made it here, right? So I don't know, I think depending where you are and the situation you're in is really going to be dependent on how fast you're going to get into somewhere. You know, maybe if you know somebody, you know, or the fact is maybe somebody in the community can help you out, you know, but yeah, it's a struggle for guys to get back into treatment or even to detox, because a lot of places are so full right now that there is no beds available. So what are you going to do? Go to a homeless shelter? You know, you're not really getting clean and sober out of homeless shelter. So yeah.
I can say I've experienced some stigma within my family. As I do love them, and I know they love me, but particularly with my dad, he doesn't, he's at times not fully educated on substance use disorder. And what I would say is, like, he comes from the old school mentality of it being more of a moral or a control issue. And at times is more suggested that I just go back to work. And if I'm working, then I don't have time. If I'm taking on the normal responsibilities of functioning members of society, which obviously I'm not able to do as I struggle with the substance use disorder. And our house has been there. They're like my family away from my family, that's taken me back and coached me through addiction and recovery from the standpoint of it being a disease, which I wasn't able to get from certain family members.
The biggest barrier, I think, is time, for me anyway, is the amount of time it took me to get into, I went to Henwood prior to coming to our house, so, and that was a very long wait. And then between Henwood and here, there was quite a long wait at that time. That'd be 6 years ago. But I had the good fortune of having a really loving daughter who took me into her home for the 5 weeks I waited to get into Henwood, and then between Henwood and here. So, but I know for some people, 5 weeks, 6 weeks, 7 weeks, whatever, waiting, and like the boy said, with nowhere to go would be an extremely difficult experience to face.
For myself, like the barriers, I kind of set everything up myself. Like I set up a detox date, I set up a treatment date, and then I'd already had an application put into our host, but I had to do the legwork myself. There wasn't a whole ton of people that were willing to do the legwork, to help me do the legwork, but that's being in and out, in and out. I've been in and out of recovery so many times, and I've been to treatment so many times that I kind of learned what I needed to do in order to get my foot in the door. But the barriers I found was through work, was probably and the stigma was highest in the job. I work oil field, I'm a welder, and so there's a lot of substance use that's in the trades, and in that trade specifically. And a lot of people have the substance use problem, but the second you go and say that you have a substance abuse problem and you recognize it and you bring it forth, there's almost like this thing that, well, we don't want you working with us because you've diagnosed yourself as an addict. You know, like, I'd say the stigma is biggest with work.
Mhm. Yeah, absolutely. I've heard that many times. Sorry, Ed, did you have something you want to say?
Oh, I was just saying, I can definitely agree with what Sean had to say, because I'm a union iron worker, and part of my trade, there is a lot of drugs, there's a lot of booze, you know what I mean? We do make a lot of money, we travel out of town a lot, you know, so there's not really a lot of responsibility there, but at the same time, whether you are using substances or you're drunk, whatever the case is, as long as you can do your job, they have no problem with keeping you. So to continuously being able to, you know, continue that destructive lifestyle, it kind of really hindered what I was trying to do by getting healthy again, right? So taking the year off from my job is actually kind of a benefit, you know, because then it allows me to figure out what it is that I need to do if I do decide to go back to that career, or if I decide to change it, right? You know, because the fact is, if they're willing to enable you and continuously allow it to go on, how far are you really going to make it in life? You know, so that is a huge problem.
Yeah, absolutely. Thank you. And what do you feel is the most important way that we can reduce stigma for people who use substances? So, you know, we're talking about education, and tonight learning about what some of those stigmatizing language can be, for instance, or looking at how stigma is sort of within the structures and the systems. What do you think would be the most effective way, or the most beneficial way to try to reduce that?
I think lead by example and just show them that recovery works, you know, for people who come off the streets, or, you know, maybe come from a negative background, I guess, or even people who come from high status in society. You know, everybody does have an addiction or substance abuse problem, but a lot of people don't admit it, right? So I think to see people who come from different walks of life enter into treatment centers and then walk out a whole different person, I think will allow the community to see that this actually works. You know, this is actually benefiting the community, one, financially, two, you know, violence stays down, crime stays down, people are getting healthy. You know, there's nothing that is a negative about a treatment center. You know, there should be no disruption to anything. It should be more praised, you know, because guys like myself, who what I used to do for a living is not something that I choose to do now. And because I'm in treatment and I've been able to change my life around, it's something that I'll view as going back out onto the street to show another person that, you know what, this is where I come from and this is what I'm doing now. And this is how I did it. So I think that, you know, leading by example is key.
I think taking the model of, like, say, countries like Switzerland and Sweden, where they say that 80-something% of people that are incarcerated are due to some sort of drunk or drug charges or something like that. So instead of locking people away and creating a worse criminal, or creating, you know, something, yeah, locking them away, caging them away like an animal, instead give the options to go to treatment, and give more options to have the ability to recover. And they've been proven, like, they've been shutting down prisons left, right, and center in these places, because there's no longer that stigma that, oh, now not only are you a drug user and alcoholic, you're a jail person now, and you're this and you're that, and you're just some kind of monster. Whereas if you take that person and give them the chance for rehabilitation, I think that's going to change. That's going to be a huge game changer in Canada if we take those models of those other countries.
Yeah, so it'd be to me, it would be a two-factor thing, early education, which was what you were talking about in the presentation, whether it be in, you know, junior high or earlier, and talking about, you know, substance abuse, that sort of thing. And then leading on to what Sean was saying, expansion of programs. I mean, here in Alberta, we have drug court. And I think drug court, recently, they just expanded it. I think I don't know what the actual numbers are, but they incorporated in Grand Prairie and Fort McMurray. And so people that are convicted of drug-related crimes, if it's under 5-year sentence, they have the option of going to drug court instead. And that has really helped reduce the number of beds required in prison. And I think it's really helped to reduce the number of repeat offenders.
Right.
For myself, I don't know how many times I've been in a module, which is our classroom settings here in the house. And I hear guys say, I wish I would have known this when I was a kid, education on these subjects. I mean, I don't want to pick on like a particular subject like biology, but everything I learned about meiosis and mitosis didn't help me nearly as much as the life skills I've been taught here that would have benefited me far more knowing earlier in life. Subjects like codependency, self-esteem, healthy relationships, the list goes on throughout the 9 modules I've taken here. I would have benefited exponentially had I have known some of those skills earlier in my life, and I would wish that for any kids, whether they have a substance use disorder or not. You know, if that could wiggle its way into the curriculum for the young ones, I believe that would be a benefit to them for sure. And as well, the kids, if they, I mean, substance use disorder is something that impacts a lot of families, right? And a lot of people out there, everybody knows at least somebody with a substance use disorder and they're touched by it, right? So, and they see the ugly side of it when they see someone in the addiction side, right? So if they had more contact with people that are in recovery and have turned their lives around, and to know that there is the potential for a healthier, more balanced life for people that have struggled with substance use disorder, for them to see that and to hopefully inspire them. Because I lived many years in denial, right? And had I have known that there actually was hope, I would have entered recovery more likely in my 20s as opposed to my late 30s, right?
Yeah, absolutely. All right. Are there any questions from our guests relating to either anything that the gentleman said or anything in the presentation that Ashleigh had? Mike, you have your hand up there.
Yeah, the gentleman that was talking about the courts and the jail, you see, that's very important, what I heard, what the gentleman was saying, because at least there were, like, the society now is reaching out to the people, the drug users, that because they're noticing now, because of the drugs and because of the drinking, they commit crime, because I did. I spent almost 14 years in prison because of the drugs and drinking that I did. And thank you for that, brought that subject up. And I used to work with Human Services and Justice Coordinating Committee. And I was on that committee because I was appointed there because I was helping looking at the jail system. And this was why I was appointed there, because it was a director that appointed me to that position, because I was working with judges, lawyers, crown attorneys, higher up people, and I was a spokesperson for people in jails and people with mental illness and the drugs and drinking. So thank you very much for bringing that subject up about the drugs and drinking, because now it's right across Canada. Thank you. Thank you.
Thank you, Mike. Nicole, you have your hand up there, I see.
Yes, I'm on my cell phone, so because my computer crashed, so I'm trying to figure out how to open my mic and stuff. But I'm really happy they talked about the education, because codependency, I had no idea that I was so codependent. That I just started, that's how I started thinking with my drinking is, and then it became a problem. And my father was very emotionally and physically abusive to my mother. So there was a lot of patterns in the family, and I'm the only one that's actually in recovery, even though I have sisters that are in denial, and one's highly functioning. She's a very good job with the government. But I heard we have what's called in our area Gratitude Week, and there was doctor's professor, or I think anyway, she has some degrees, and she spoke about childhood trauma and how we can get better through recovery, but the depression stays. And it never occurred to me that I had suffered childhood trauma as a result of my father's drinking and violence, like hiding in closets, that perhaps that was why I a single mom, when my mom left him at a time where women didn't do that. So she had stigma. We're talking about stigma from the family, from her brothers who didn't have any children, and she was never able to get emotional support from. So it's all, when I share, I try to talk about that, try to talk about patterns and dysfunction, and as a result, it was always about my drinking, but I realized that, well, what about the two sisters that are in denial about their addiction or addictions, and the other two, the other brother and sister that, are active. One's highly functional alcoholic, and the other one, well, his health is starting to suffer. There's patterns, and my uncles are super heavy drinkers, and an uncle who stopped, but not through treatment. He stopped, I guess you could call him, but his behavior, it's borderline. The isms are there, he's so he's not. I don't know if he's all together such a happy person, but I really appreciate it and want to thank the guys for talking about their experiences. It's important to hear that. And Ashleigh too, I thanked her in the chat, but wanted to thank her for, I think she did amazing. It's incredible what some people in recovery are able to accomplish. And we should tap ourselves on our backs for what, when we do try to help one another. And it is important to help and support, and that's what we're doing tonight. So thank you for Rebecca as well. Thank you.
Thank you, Nicole, for sharing, and thank you, Mike.
Rebecca?
Thank you to all of you. Did you want to say something, Ed?
Hey, I just wanted to echo what I think Ashleigh is her name, the presenter, was saying about self-deprecation and like coming into our house and going to get into treatment. Like when I first came in, I thought I was a monster because I was a victim of substance abuse disorder, and I didn't think I was a victim of substance abuse disorder. I thought I was an addict. I thought I was a junkie. I thought I was this, that, the other thing, and I thought it was all negative, right? And I was able to find over the last 5 years that maybe I'm not a monster, that I'm just a person that had some issues, and so education is important. Early education is important, but guidance for ourselves to let us know that we're not that bad, and it's just I've got diabetes, and it's not my fault I've got diabetes, and it's not necessarily my fault that I have substance abuse disorder either, right? So I'm not necessarily a bad guy just because of that.
Not at all.
We're not bad people trying to get good. We're sick people trying to get well.
That's right. So thank you again, gentlemen. Thank you, everybody, for your questions and sharing, and Ashleigh. And I'm going to turn it over now to Kim.
Hi, folks. I'm just going to kind of keep the gratitude going and wrap it up. So that is what we have today. So a huge thank you again to Ashleigh for walking us through the stigma of substance use, changing the narrative. Also, a thanks to Rebecca for moderating, and to our client panelists, Ed, James, Sean, and Sean, and to you guys, the audience, for taking time out of your very busy lives to join us. A reminder that the webinar recording will be posted onto our website shortly. There will be a brief post-webinar survey that will launch after this session. So if you have any additional questions that we weren't able to answer your question today, you can add to that. But thank you guys all so much, and we will chat later. Have a good night, folks.